Good afternoon. It's a great honor for me to co-chair this session with Professor Kathy Jenkins, who is one of the most exceptional leaders on the field of congenital heart disease worldwide, and also a very big patron on humanitarian medicine.
Thank you very much for that kind introduction, and I'm also very pleased to be co-chairing this session with you and to be here at the Global Forum. Dr. Petropoulos, I believe you're also going to be our first speaker. Is that correct?
That's true.
Very good. Very good. Well, I'm really looking forward to just hearing your presentation. I'm sure the topic you'll be talking about is something that many people will be interested in. So I will hand the platform to you to share your thoughts and your presentation.
Thank you so much. So, prevention and early detection of congenital heart diseases. What would be the best practice in low and middle income countries? I have no disclaims. And as we know, every 15 minutes a baby is born with congenital heart defects. 50% of these children will die during the first year of their life, and from these children that will die, 50% will die in the first month of their lives. So the aim of my presentation today is to arouse suspicion towards congenital heart diseases, to increase the detection of congenital heart diseases in the early postnatal period, to discuss briefly the role of the neonatologist and the role of the pediatrician in detecting early these defects. Now, how common are congenital heart disease? They are the most common congenital malformations, and they have an incidence of 1 to 1.6, maybe even more in different countries, or in the way you are counting these defects in 100 live births of the general population. 10% of these will be spontaneous abortions due to the severity of the defect. 50% of deaths occur, as we said, in the first year of life, and these congenital heart defects are determined as severe. 50% of the deaths of congenital heart disease will occur in the first month of life, and these are known as critical congenital heart diseases. So, critical congenital heart diseases, arrhythmia, and impairment of function secondary to ischemic immediately postnatally conditions consist the bulk of cardiac problems found in the neonatal period. Newborns seem healthy initially, but in a few days present as critical ill neonates. As we all know, it takes approximately until the end of the 50th day after the consumption for the cardiogenesis of the cardiovascular system. So everything that will go wrong will go in these first couple of weeks after the consumption of the fetus. From the very well-known work of Abraham Rudolph on congenital heart disease, we know that pulmonary and systemic circulations during fetal life are parallel. We also know that one ventricular is only needed in fetal life to sustain fetal life. A right ventricle is the dominant, and from the total cardiac output, 55% is delivered by the right ventricle and only 45% from the left. During embryogenesis, size and function of a chamber, a valve, a vessel is determined by forward blood flow supplied to the structures. As we said previously, the cardiac output will be divided for 43% in the upper body and 57% will be for the rest body. pulmonary vascular resistance are high in fetal life, and they normalize in term babies after 6 weeks old. The saturation is generally low during fetal life, with the ascending aorta carrying oxygenated blood with a saturation of 68%, the descending aorta of 57%, the right atrium of 30%, the left atrium of 35%, the right ventricular of 53%, and finally the left ventricular with 68%. So with these basic knowledges and knowing the adaptation that the circulation will take place after birth, mostly with the restriction to the flow from the duct to the lungs, the ductal flow will close and the pulmonary branches will open 8 hours after the baby has been born. And finally, we will have a closure of the ductus in 24 hours, in most cases in term babies, and the pulmonary vascular resistance will drop after the 2nd month of age of these babies. Now, going back to numbers, the prevalence of congenital heart disease worldwide today has rose from the number of 1% to 1.2%, even up to 1.8% of live births. And in the fetal population, you can see that this number is higher, coming up to 33.5%. Our research in Azerbaijan showed that the prenatal percentage of congenital heart disease is approximately 3.2%. And from the national prospective study we did, we have an incidence of 1.48, 1.5 nearby percent of congenital heart defects. From these defects, critical and severe of 51% and cyanotic of 50.7%. Probably this is due to the specific cultural reasons we can find in Azerbaijan. Now, going back to the history of the newborn screening, we must remember that in the 1960s, the Guthrie test that had the opportunity to give us a detection of 3 basic error of metabolism conditions was the initial part of newborn screening. As time goes by, we can see that in the 1970s, hemoglobin disorders and congenital hypothyroidism was added to that. Later in 1980, sickle cell disease. And as you see, as we come up to the 2000 and 2006, we have now the uniform screening panel of systems that gives us the detection of many more conditions. And we know that today, at least in the United States, the basic screening for malformations in the neonate period are a core of 35 plus 26 secondary diseases. What is a turning point for congenital heart disease defect is the 2011 period in which we started to add in our screening programs the use of pulse oximetry. Okay. And you see that in 2012, New Jersey was the first state to mandate the screening. And since then, from 2013, the use of pulse oximetry as a screening tool for early detection of congenital heart disease is a benefit that many states in the United States use today. Now, it's astonishing to see that for many years we were screening for diseases like cystic fibrosis, hypothyroidism, and phenylketonuria or marble syrup urine disease, in which you can see the incidence are very, very lower than the incidence of critical congenital heart disease or congenital heart disease. So this slide is here to underline the need of having a measure and an index for early detection of congenital heart disease. And when we say critical and severe congenital heart disease, we must know that using these terms, we are requiring conditions in which surgical or catheter or pharmacological intervention is needed to avoid death or end organ damage in the first trimester in the first month of life. They are mostly either univentricular physiology conditions or systemic or pulmonary duct-dependent circulations. And some examples of these will be the hypoplastic left heart syndrome, pulmonary valve atresia without a VSD, tetralogy of Fallot with an absent pulmonary valve or tetralogy of Fallot with pulmonary valve atresia, double outlet right ventricle with aortic valve stenosis, or the Townsend-Bing condition, total anomalous pulmonary vein drainage, and mostly the obstructive type of this, TGAs or TGAs with critical coactation, tricuspid valve atresia, truncus arteriosus, and also we will have three different conditions that are not cyanotic, but they are severe left heart obstruction disease as a severe obstruction of the aortic valve or a coactation, as well as an interrupted aortic arch or children that are born with Schonn's complex. So, what are our screening tools? Medical history and physical examination is something that you can find in all parts of the world, even in the countries that have limited health facilities. Fetal echocardiography is an excellent tool, but it's quite expensive and it won't be able to be found in most low economic countries. But pulse oximetry is something that we can use in any kind of surrounding. Let's start from medical history and physical examination. So prenatal diagnosis of congenital heart disease or syndromes are very handy because if we have a family history of previous congenital heart disease in the family, or we have any specific risk factors as maternal age, maternal diabetes mellitus, the use of teratogenic agents, or even systematic lupus erythematicus. These are conditions that can provoke congenital heart defects. Now, when a baby is born with tachypnoea or a pathological murmur, if a baby has cyanosis with a saturation less than 90% in the end of the first day of his life, or a difference between the preductal and the postductal saturation over 3% in term babies after the first day of the life, these are specific signs that need to point to the possibility of the existence of congenital heart disease. Now, poor pulses or a low perfusion index, and today we have devices that also can measure a perfusion index, not only a saturation, will help detect conditions that will present with low cardiac output. So the use of pulse oximetry in the neonatology resuscitation protocol from 2016 has changed the APGAR scoring and has given us the opportunity to understand cyanosis even in children that have darker or yellowish skin. Clinical presentations as family history. So syndromes like trisomy 21, 18, 13, the George syndrome, Williams, Turner, Alagil, Marfa, Noonan, and Charge are typical syndromes that have a quantity of congenital malformations. In trisomy 21, maybe the most common, in which we can find it in one case in every 800 births, and with the use of nuchal translucency, that will exist more than 3 millimeters in measure, as you can see in the upper part of the slide over here. It is a marker of a possibility of Down syndrome. And as we know, 40 to 50% of children with Down syndrome will have a type of severe congenital heart defect as a common AV canal or even tetralogy of Fallot. What's most important to remember from these patients is the high risk for early pulmonary hypertension, as these patients have this disadvantage. Now, trisomy 18 is a more rare condition. Also, what we need to remember from this syndrome is that 95% of it will have a type of congenital heart disease, and also that these patients are shortly lived patients. Trisomy 13 is also a defect that has a high prevalence of congenital heart disease. Major neurological impairment in these patients is something we need to remember. The George syndrome, very well known with cardiac abnormalities, up to 80%, and most of them difficult abnormalities to treat as conotruncal defects, as tetralogy of Fallot, double outlet right ventricle, or interrupted aortic arch type B. Thymus dysplasia is what we need to remember from these patients, and also the possibility of hypocalcemia that can create problems in the first hours of dealing with these patients. Williams-Brewer syndrome. One case in 10,000 births of the general population, 55 to 80% will have a congenital heart defect, and this will be either a supravalval aortic valve stenosis, pulmonary branch stenosis, and also coronary artery stenosis. And this is something we need to keep in mind and treat these patients as early as possible. Turner's, a condition in which we will have approximately 30% some type of congenital malformation of the heart, but we need to remember that the girls with a phenotype of Turner will not have a menstrual period or female adult phenotypes. Alagille syndrome, another rare condition with 90% of congenital heart disease, and what we need to remember is the chronic cholestasis that will create more complications in the dealing of these patients. Finally, coming up to Marfan syndrome, one case in 5,000 births of the general population. We need to remember here also that we have a Marfan-like phenotype in which we have some elements of the syndrome, but the patient is normal in his cardiovascular system. Noonan syndrome, not a very rare syndrome, autosomal dominant way of heredity. 80 to 90% of these patients will have supravalval pulmonary valve stenosis, and also an amount of them will suffer from a specific type of hypertrophic cardiomyopathy. Chard syndrome, quite rare, but will have an element of 60 to 90% of congenital heart defects, and these are critical conditions like tetralogy of Fallot, double outlet right ventricles, and common AV canals. So coming to the physical examination, the vital signs, capillary refill time, and feeding and feeling extremities of the baby are very important. To inspect the facial and body features so you can early detect something that will be abnormal and help you to detect one of the syndromes we discussed previously. Pulsation of the peripheral pulses and the size of liver, respiratory patterns for respiratory distress syndrome. The urine output must be over 2 ml per kilogram per hour. And remember that murmurs in 50% when they present, they can be also either innocent or obstructive. So passing now to how we will increase the detection of congenital heart disease in the early period. As we discussed previously, fetal cardiology has done a major change in early detection of congenital heart disease. We can screen today babies from 11 to 15 weeks old, but the majority are screened when they are 21 weeks and above. It is a technique where we need a collaboration using a state-of-art machine, ultrasound machine with Doppler color flow and power Doppler. The sensitivity today has increased up to 80%, and the specificity for well-trained pediatric cardiologists that do fetal echocardiography has raised to 98%. But this is a trade that is expensive and limited. Indications, most of them you can see them on the slides, and when present we need always, if we have the capability to offer a fetal echocardiogram, to do so. This can also bring us to prenatal treatment conditions that will help the outcome of the patients that will be born, and three of the major indications: fetal arrhythmias that can be treated by delivering medicines, antiarrhythmic medicines to the mother, in progressive defects like severe aortic or pulmonary valve stenosis that can lead to hypoplastic left or hypoplastic right syndromes. We can always have the possibility to use an interventional procedure to change the outcome of these babies when they are born. And finally, when we have severe pericarditis due to fetal hydrops, we can today drain this pericardial infusion so we can give a chance to the baby to survive and deliver. But going back to fetal cardiology, the average cost per scan in the United States is approximately $300 and other $400 for a consultation. So in United States, $700 will be the price for a fetal cardiology evaluation, plus the special equipment, plus the rare subspecialty in human resources, and this creates a restrictive approach toward the local surgical capacity that every country has. Because what do you need a fetal cardiac center when you don't have a surgical capacity in this country to deal with the neonates that will be born with severe or critical congenital heart defects? So we come now to the role of pulse oximetry, in which you can see that the initial sensitivity that was published back in the 2000s was 76.5% and the specificity about 77%. That means that for every 3 detected cases as positive patients, one would have another pathology, as early sepsis and respiratory distress syndrome can produce low saturation as a finding. Not meant to replace fetal echocardiography or clinical examination, but to work additionally with that creates a very good screening tool for early detection of congenital heart disease. Let's see now some data that was published in 2014 in the Lancet. So this is a very interesting study coming from China. And you can see that only in a country like China you can have a study of 130,000 term neonates. So the population of this study is so high that the numbers that it delivers are very accurate. We can see that The patients were screened by pulse oximetry, medical history and physical examination 6 hours after delivery and 72 hours before they were discharged from the maternal hospital. Asymptomatic newborn sensitivity for pulse oximetry plus medical history and physical examination was 93.2%, and for critical congenital heart disease and 90.2% for severe congenital heart disease. So the best screening will be as late as possible using pulse oximetry plus a medical history and physical examination by an experienced neonatologist or pediatrician will help up to 97% of these patients to be picked up early so they can stand a chance for a better survival rate after the initial treatment. The next study I'm presenting to you comes from Italy, and it's a very interesting study that took place in 2017, trying to explain that the use of pulse oximetry with the use of a perfusion index, in the hands of experienced clinicians in a tertiary hospital, increased the detection of critical and severe congenital heart diseases when they were compared with the detection rate without these tools in a non-tertiary hospitals surrounding. So coming to the results, we can see that the initial population that was screened is 42,169 asymptomatic neonates. That's a very big number for a study population. And in these they found 142 babies that had severe congenital heart disease that was detected only postnatally. So that gave us an incidence of unexpected severe congenital heart disease, one case in 1,115 births. This number was similar, either the baby was born in a tertiary or a non-tertiary hospital. Now coming back to the screening, in a tertiary hospital, they had the opportunity to find, 3 out of 7 cases that had critical congenital heart disease or severe congenital heart disease. The cases that were detected with low saturation was double outlet right ventricle in 2 cases and 1 case with coarctation of the aorta with a low perfusion index. They missed another 4 cases that were mild coarctations, probably because the use of the tool of perfusion index is still not aroused to its best use. So studies will need to continue so we can find the gold standard of what would be the lowest normal number for a sufficient pulmonary index, perfusion index in a child. Coming back to the tertiary hospital results, you can see that 95% unexpected congenital heart disease were identified, with only 28% of them identified in a non-tertiary unit. But when you use the tools, of pulse oximetry and physical examination plus the perfusion index in screening, the detection rate in non-tertiary hospitals raised from 28% to 71%. And this is something very important. So in conclusion, the study from the Italian Pediatric Cardiology and Neonatal Association says that using perfusion index and pulse oximetry pre-discharge screening provided benefits in non-tertiary units where clinical recognition rate was low. Perfusion index can help to identify cases of coarctation in which we don't have any desaturation in the early hours of these patients, so they are missed on pulse oximetry screening. But this requires further research. Coming to the end of my presentation, how do we screen these patients? So what we need to remember is that we will screen always the preductal area, that is the right arm, and any of the limbs, either the right or the left limb. Even in some cases you can screen the left arm because all these limbs are postductally. What is the normal cutoff for saturation of oxygen in a term baby after the first day of its life will be 95% and above. So any baby that scores under 95% after the first day of its life fails the test. We can repeat the test in 1 hour. If the baby fails again, we can repeat the test in another 1 hour. And if it fails in 3 tests, okay, then probably we need to go to the next part of our algorithm, that is to examine furtherly this baby for the possibility of the existence of a congenital heart defect. So we also need to remember that if we have a difference between the upper and the lower measurement, then this more than 3%, that means that probably we have some kind of coarctation or interruption in the blood flow from the aorta to the lower extremities of the body, and this is something that we need to take in consideration and screen these babies. So this is the algorithm that we have presented with the Greek Perinatal Association in 2021, how we do the screening in our country using pulse oximetry, physical examination, and medical history to early detect children that are born with critical or severe congenital heart disease. Finally, if they fail the test, what we need to do is we need to perform additional clinical evaluation to assess or not no cardiac causes or cardiac causes of this desaturation, and echocardiogram is one of the most important next steps if we have a false measurement in the pulmonary saturation protocol. Now, clinical presentations of these patients can be either cyanosis, and we are discussing central cyanosis, but please be aware that in babies we have a condition that is called the blind sign, and this is due to the high quantity of hemoglobin that these babies have. So what does that mean? That means that when a baby has a hemoglobin of 20 grams per dl, the saturation must drop under 84% for a clinical detection of the cyanosis. Now, please remember also that we have a differential diagnosis of other conditions that can mimic a central saturation, and these more important conditions and more frequently seen as persistent pulmonary hypertension of the neonates. It's distress during delivery, it's meconium aspiration, and it's also the possibility of the mother using non-steroid anti-inflammatory drugs prior to delivery that will have as a consequence the early closure of the ductus arteriosus, so increasing the pulmonary vascular resistance. Also, primary lung disease can create severe respiratory distress and mimic conditions of congenital heart disease. Late onset of transient conditions in congenital heart disease can be late onset of difficulty to feed the baby, or the baby crying during feeding, or the baby being cyanotic or mild tachypnoic. Now, what we need to remember is that using a hyperoxia test is the best way to differentiate a congenital heart defect of any other sepsis or lung condition that can mimic a low saturation. Okay, the next clinical presentation can be decreased systemic perfusion, and we see this mostly in left heart obstructions like coarctation and also severe interrupted aortic arches that will not give us a desaturated condition if we don't have a patent ductus arteriosus or a patent foramen ovale, but they can create tachycardia and a clinical presentation of heart failure due to different other mechanisms you can see over here. And anemia and polycythemia are two of these, as well as metabolic acidosis from a non-controlled diabetic mellitus of the mother, or even hypocalcemia and hypoglycemia. Having myocardial dysfunction, inotropic support and reduce of afterload is always needed. And finally, the third presentation will be tachypnoia. Now, tachypnoia is a sign of congestive heart failure. It is secondary to a congenital heart disease, but never presents from birth, with one only exception, and this exception is the obstructive type of total anomalous pulmonary vein drainage. So early neonatal tachycardia after the second or third day of life due to the closure of the ductus arteriosus can be a marker of severe aortic valve stenosis, coarctation, or interrupted aortic arch. Acutely after the birth, the possibility of cyanosis can also be a lung disease, but if we have a baby that presents with failure to thrive and diaphoresis later in above his first week of life, then we have an increased possibility of this patient suffering from a congenital heart defect. So what will be the role of the neonatologist in this condition? To suspect and detect as early as possible the existence of a critical or severe congenital heart defect, to stabilize the neonate before surgical or interventional management, to be alert for late onset presentations of congenital heart defects, to inform the family that an absence of a chronic or severe congenital heart disease in early neonatal life does not exclude severe or moderate congenital heart disease. And the aim of the pediatrician to suspect a missed severe, at least congenital heart disease during the initial infantile assessment at age 25 days old or during the 6-week well baby check. Remember that moderate to mild congenital heart disease may have late onset presentations, act as the primary care physician of the suffering from congenital heart disease, doctor, physician is the most important for preserving the life and quality of life of this baby. And also to remember that long-time support in the family with a child suffering from congenital heart disease is the most important element. So in summary, you can see in the slide that we have prior to pregnancy, immediate prenatally, and immediate postnatally conditions and tools that can help us early detect congenital heart disease. My take-home message is that congenital heart disease, or frequently neonates, they are difficult diagnosed when fetal circulation persists. Pulse oximetry is an excellent screening tool. Physical examination is vital, and differential diagnosis is essential for the life saving of these patients. Initial treatment must be offered by an neonatologist on demand, and pediatric cardiologists will establish the diagnosis and initiate special treatment. So, the take-home message will be, if we truly want to change the outcome of these babies that are born with congenital heart diseases, and if we truly want to minimize the mortality and morbidity of these patients, physical examination and the use of pulse oximetry are the best ways for early detection and planning treatment strategies in mid and low socioeconomical countries, because both of these tools are easily found and the cost of using them is very low. Thank you for your attendance, and I'm here ready to answer any questions.
Well, thank you so much, Dr. Petropoulos. That was a really compelling and comprehensive presentation on all of the issues associated with newborn screening. I would just like to really congratulate you on the national study and the results of that you showed. And I'm just really thrilled to see the algorithms you've put together and training programs in Greece. May I just ask one question, and then I think we'll need to move on in the interest of time. How successful do you think things are in Greece right now in terms of really implementing the screening programs that you're talking about? Where are the trouble spots and where are things going well?
Well, I think the best thing we have established is the protocol that we published back in 2021. And as you can see, this has also a background from your own studies in the element of using pulse oximetry as an early detective condition.
Yeah.
So we are using since 2020 this algorithm, and we have achieved an early detection of most of the cyanotic type of congenital heart defects. Now, the true puzzle will be the severe congenital forms that do not have cyanosis, as the left heart obstructions. So I believe that the next step will be making as best as possible the use of perfusion index.
Yes, really interesting. I will say in the United States, it was the parents and patients that fought the US government to get pulse oximetry on the screening programs. And most states have them now. I think we should move on. Thank you very much.